Okay, so welcome everybody. Today is Tuesday, April 28th, 2026. This is the ClinX Academy office hours. We're doing a public session today, so we've invited both existing ClinX folks and some folks from the public whom we don't know necessarily. So welcome everybody. We have a special guest today, Alex Mitchell, who I will pass over to Reza to introduce him, and then Alex will pass it over to you to get started. So this is supposed kind of high level, like before we get started. So we're gonna start with Reza and I kind of peppering Alex with some initial questions and some initial topics that we wanna do. Then we'll open it up to kind of more kind of open question and answer with the rest of the audience. So I'll hand it off to Reza now.
All right, guys, I'm super excited to welcome Alex. We overlapped briefly at Optum. He was a big deal while I was just like a regular medical director. At some point, he reported up to the CEO of UHG at the highest levels, was CFO of OptumCare, and then got to really work closely with him when I was at Dispatch for a short period of time. Beyond being a CFO and leader, he's also very personable. I've gone to his house in Minnesota, and we hung out in New York while he was at Render. So, this can be an informal conversation. Just want to start turning it over to Alex and give us like the origin story, like maybe a minute, not 20 minutes. Just give us a minute from like where you decided to study, I don't know, finance, accounting, wherever you were, and how you got into UHG.
Wow, Reza. Okay, thank you for the introduction. Great to be here, and look forward to the dialogue and the questions. And then, as Reza said, just a general dialogue around things that people are interested in talking about. In terms of where things started, Reza, we can go back to the very, very beginning, and I'll just say that I am humbly a small town Wisconsin kid that grew up on basically a dirt floor, and somehow happened to make my way to the University of Wisconsin, and from there up to the Twin Cities, and was a retail manufacturing and distribution person at Ernst & Young. Actually served Warren Buffett's Berkshire Hathaway. And lo and behold, this is how random life is. The individuals at Ernst & Young said, you know what, UnitedHealth Group is one of our largest customers, and we are having a relationship problem. So you know nothing about insurance, you know virtually nothing about healthcare, and but you're good at relationships. So we'd love to have you come and develop a relationship, and I did that. And after about 6 months, United said, why don't you come over? And I looked at it and said, you know what, stock said it. $60 to $90, and I like the team, and I like the mission, and that's where it started. That's the origin story. Then I got into the universe of United, and from there you can have a career inside of a career inside of a career, and that's what happened to me.
I guess before we get into all the different layers of Optum and United and so on, at the highest levels, people hear the word CFO. And whether it's a CFO of a small company, big company, risk-bearing entity, strategy related, like CFOs can do a lot of different things. So I guess I'd love your lay of the land. If someone hears tomorrow we're having a meeting with the CFO, what are the different categories of CFOs in healthcare? How would you bucket them?
Yeah, that's an interesting category or question. I think I'd probably just bucket it in two camps. One is a very accounting-oriented CFO. So accounting-oriented, controllership-oriented. They want to close the books. They want to close the books accurately. They want to focus on an audit. That's one. Another end of the spectrum is a strategic CFO. So the strategic CFO is going to make sure the trains run on time, but they're going to be digging into operations. They're going to be helping the business understand unit economics. They're going to be really focused on forecasting, embedding finance into an organization, how you think about raising capital and things of it. So it's completely different discussion and dialogue and an interaction for the clinicians with those two different styles of CFOs. I happen to be in the strategic finance category, and believe that if there was an optimal personality type, it's clearly in strategic finance. No question.
So Alex, our audience is mostly physicians who are like along the path of moving from working clinically to some sort of medical directorship, then CMO or startup advisor. So a lot of folks are either currently or soon will be working with various solutions that are selling into health systems, into health plans, into risk-bearing entities. So talk to us a little bit about your experience with having a physician executives on your side, as well as on solutions selling into you. Kind of what have you learned in terms of good habits, bad habits, mistakes, lessons learned, that sort of thing?
Yeah, well, appreciate that question. I'll just say from a CFO perspective, make sure you know your numbers, right? Know the numbers, have gone through the math, really understand the value drivers of the organization that you're seeking to sell your offerings to, right? If it's a payer, what does the payer care about? If it's a delegated medical group, what does that delegated medical group care about? If it's a health system, what's important to them? I'd say I've seen a lot of things that have come onto my desk that maybe sound good, but the underlying math and the linkage back to what drives the business has been unclear. So if there's one piece, what's that, Reza?
Yeah, so give us an example. Help people digest it further. Like, so you're sitting there at the OptumCare, let's say, seat. Someone's trying to sell a solution into Optum, and like, give us an example where you're like, nah, the math doesn't add up on this one.
Yeah, let me try to think of something specific. Maybe it would be, we've got a solution, and it's going to reduce your admits per K, right? It's going to impact your Part A spend. We know that's the biggest spend driver as you think about medical costs. And a lot of these things can be point solutions, right? So you might say point solution A reduces the admits per K, but point solution B does too, and point solution C and D. I'm trying to come up with a specific example, but I think there's just generally speaking, there's an a tendency to want to attribute reductions in medical costs to a specific solution, when in fact there's a whole host of things that is impacting something like an admits number.
Yes, I think there's a couple interesting points here, Alex, in what you're saying. One is folks need to know the right lingo, right? So at Optum, we call it admits per K. Some other places, they call it APT, admits per thousand or whatever. So you got to know what are the metrics and what's the lingo that the buyer's entity uses. That's an interesting one. Second is a really interesting point that you bring up, which is you, the solution vendor, are only focused on one solution, your solution, right? But the buyer has 50 solutions that they have purchased and deployed. So the buyer has an attribution problem, right? So,
yeah.
And people don't realize that's actually really difficult to resolve when you have 50 different programs. You can't give the credit to everybody, especially if the contract you have for each of these vendors is on some sort of like percentage of shared savings. Well, then you're going to lose money if everybody, right? So this is really tricky.
Yeah, and there's a focus element there too, Alex, to all the context of all those different point solutions, right? There's only so many things that an organization could do. We've got a lot of clinicians on this phone. If you think about the clinical workforce, right, there are only so many things you can ask them to do and do well. And at some point you run out of capacity. And so you, as an executive, internalizing these various presentations around solutions, that's one thing that's going through my mind every time. What's how do we think about focus? How quickly can we get to the benefits here? What's the impact on the other 10 things that we need to accomplish? Is this the thing that we want to go after right now? And then let me also add, I think there's another interesting point here that came up with the value-based care provider that I was having a discussion with recently. When I think about let's say solutions that are going after total cost of care, I'm thinking about and are affordability oriented. As a CFO, I'm thinking about in the context of PMPM surpluses. So I am generating a certain amount of profitability per member per month, right? Let's say right now today with V28, the Medicare Advantage, they were feeling pretty good about $200 PMPM, right? But if you came to me and said, hey, I can addressing all the things that we just talked about, I can save you $10 PMPM, so I can reduce the medical costs by $10. And that needs to be adjusted by a pop rate, so it comes to the bottom line. Or I can do it by $20. That's a 10% increase in my profitability, right? And so I think a lot of times when individuals are coming to me presenting ideas, they're not framing it up in the context of my PMPM surpluses, right? They're framing it up in terms of total medical cost. Right, so you're saying, oh, you know what? I could save you $10 on 800. Okay, just as you're presenting that to me in that context doesn't sound as relevant. But if you're saying me $10 on 200, now I'm listening. Right, that's important.
And for our audience, right now the margins have become less, right? So before, the Optums and the ChenMeds and all these entities that used to do a lot with risk adjustment and coding. Now, what Alex is referring to, V28, the versions of the rules have evolved. So some of those codes don't translate to the same amount of dollars, where before they might have had $300, $400 of profit per patient. Now it's less. Some places are flat, so if an entity is in a particular market, making $50 per member per month, and you can come in and add $10 to that's huge in some sort of a local context.
Yeah.
Is that fair?
That's spot on, Reza. I'd say, base MA, think about 200 if you're in the DSNP populations, right, where it's a more complex population, it's a higher reimbursement from CMS. If you're at 300 there, that's you're probably doing very, very well right now in this environment.
So I want to add to this. So imagine that so first of all, why don't we start with this, Alex? Some folks might not know OptumCare relative to Optum. Can you take a minute or two just to explain Optum?
Yeah, so
it's kind of changed.
So OptumCare is the care delivery arm inside of UnitedHealth Group. So you have UnitedHealth Group. It's organized by benefits, UHC, services, Optum. Inside of Optum, there's a number of different segments. OptumCare and the delivery, which is inside of Optum Health. Then you've got OptumRx, which is the PBM, and Optum Insight, which is a technology arm of the organization. So the services business is inside of OptumCare. Obviously, that's a very large organization. I'm going to make one statement here, which I think is a really important one, and that is, if you think about OptumCare, OptumCare is really an insurance entity. The risk has been downstreamed from UnitedHealthcare and other payers to OptumCare, and in an ideal case, in the majority of the cases, it's you're taking full financial and clinical responsibility. So it's really an insurance company delivering care
with a clinical arm. It's kind of like its own Kaiser, right? Where it has its payer portion and it has the care delivery portion. So here's what's interesting for me, Alex. So I work with all these startups that are in the remote patient monitoring space, right? And in the fee-for-service Medicare space, RPM can get somewhere like $100 to $150 PMPM, all right, in a fee-for-service model. So then they come to me and they're like, hey, do you think an MA plan would be interested in this, or a risk-bearing medical group like Optum? And I look at them, I'm like, are you out of your mind? Like, if Optum's only getting $900 PMPM on a patient, let's say, do you really think they want to spend 150 of that to give a relatively healthy person a blood pressure monitor? You know, like, talk to us a little bit about some, I don't know, do you have like similar stories where people simply don't understand the basic high level math of what's in and out between, especially for risk bearing entities?
Mm-hmm. Yeah, and I think the RPM solution is a good one, and there's a question here as well in terms of who do you apply these things to, right? So in a lot of cases, somebody might say maybe it's the RPM or maybe it's another monitoring device, and they come to a risk bearing group and they say we're going to put it on everyone. You should put it on everyone, right? It just makes sense. Put it on everyone. That 99% of the time is not going to work in the context of the profitability. And so understanding the inclusion exclusion criteria, right, that says, you know what, this if it's a device that is going to address diabetes as an example, or it's going to address COPD, or a cardiac related topic, how do you get down to that small population, that targeted population that really needs that solution, right? And for that small population, if deployed, we're actually going to positively impact the healthiness of that individual, the medical cost, our understanding of the disease burden, so that we can actually treat more.
Yeah, so I guess the other thing that I would, as we pivot a little bit, I want to better understand your experience in mergers and acquisitions, right? So whether you were at the UHG level doing M&A, or some of the stuff you're currently looking at, or the stuff at Dispatch, how do you think about the clinical leadership team of a small business as they're pitching to get acquired, or after the acquisition, you want to decide, okay, these guys need to go out and we need to upskill them? Like, walk me through the range of physician executives you've interacted with. What is average? What is good? What is great through the lens of M&A?
Yeah. So by way of context, at United, I was deploying $5 to $15 billion worth of capital annually. All right, so $5 to $15 billion worth of capital annually. I've never done the math, but I've probably said no to $500 billion of particular potential acquisition candidates. So have said no to things more often than yes. I've looked at acquisitions as well in the context of DispatchHealth and in the context of Render. So really large ones. And then we've also looked at tuck-in acquisitions, which would be acquisitions. So if you've got a multi-specialty medical group, it may be a small primary care practice, right? But so a lot of experience. I've done every vertical of healthcare at UnitedHealth Group, with the exception of the acquisitions that were done in Latin America, primarily, and a few acquisitions that were done in the UK. But to Reza's question, as we think about clinical leadership, the clinical leadership is unbelievable. I mean, very, very, very important in the context of these transactions in the value-based care space or an enablement related space. Their ability, so great, is an ability to articulate a model of care. Their ability to articulate the technology that enables that model of care. Their ability to articulate how they understand the metrics. So the results of their model of care, how they've organized their functions. That's great. How they understand the financials and the unit economics. So that's great. And obviously the ability to articulate that, the ability to be a storyteller, right? To talk to the acquiring organization about, you know, who is a consumer, who is a patient. At Dispatch, and Reza knows this, we did an excellent job describing who our patients were, who they were, how we helped them, and what the outcomes were. So critical, that role is critical. An executive, a clinical executive that has the ability to really have that business perspective and who can be a storyteller.
Yeah, we have a question.
We had a question from Rami. Yeah.
Rami, go ahead.
Can I speak? You guys can hear me, right?
Yeah.
So I was just typing my question. So, you know, these opportunities you're talking about, they're very interesting. And I've been trying for a long time to find such opportunities. Brief background about myself. I'm a primary care doctor, and I was a member of the ACO in the country that approved the hospital at home model of care to Medicare. The ACO was sold in 2014 to Centene for $325 million. And I continued working for Centene. Even during COVID, we did telemedicine, but then when they saw no end in sight, they wanted the doctors to go back in the homes and do house calls, and I didn't feel it was safe. So I left, and I started going to nursing homes. 5 other doctors from the company did the same thing. So that organization of going to the nursing homes used to be owned by a doctor and his Persian wife, who was a lawyer, and subsequently they sold out to private equity. And the CEO of the current nursing home company, it happens to be the COO of the house call company I worked for. And ironically, I trained the COO on how the U.S. healthcare system worked, because that was his first job into the U.S. healthcare system. He came from CBS Radio. So during COVID, I got an MBA, and I was one of the first 300 doctors in the country to get the certification of AI in medicine. So I've been pitching him to him the idea of how badly his organization needs a chief AI officer, even if it's a fractional chief AI position, and he keeps dismissing what I say. I mean, he doesn't give a shit what I have to say, and I'm like beyond frustrated. I don't even know what to do anymore. So,
question. I sense your frustration and I empathize with it. But like, what's your question for Alex?
My question is how do I convince this guy that he's missing the boat, and this organization that they are having so many technical difficulties because they're rolling out AI, but they're rolling it all in the wrong way. And you know, it's kind of like having a certain degree of self-respect, where I'm telling this guy he needs this position, but he doesn't recognize it because he's a business guy. He's not a clinician, and he doesn't really recognize what doctors do. He just views us all as widgets to make money. And you know, healthcare is unlike any other industry, probably, I think. So I was wondering if you guys had any advice or not.
Can I rechannel your question to Alex? I guess what I am hearing is a physician leader who's frustrated that he has apparently the right content he wants to say, but it's not landing. So is there something more in how he can articulate it, who he can articulate it to, and figure out what is the lingo and the language, and how is it going to stick with the business leaders?
Yeah. So the one thing that comes to my mind, and at Render we had a clinical leader who was driving our AI initiatives, right? So we had the structure that you wanted, and our view was that we needed that clinical leader because an area of focus for us was to automate and ease the administrative burden for our clinicians via AI, machine learning, and other solutions. And to do that as a business person driving that, right, is very difficult, right? Because we don't understand, the way you would, how the clinical processes could and should work. So, with that being the background, if there was a way to articulate articulate that in terms of the benefits of the clinical perspective in terms of optimizing the areas of automation. Maybe try to do that. There's a lot of unknowns in the question here, right? Because is there a cultural, do you have cultural engagement to drive AI across the organization, right? And there's change management and all of those things that are important. But if you don't have the buy-in from the top, I'm not sure that that they're going to embrace a clinical leader, or frankly any leader in that particular role. But there's so much going on from an AI standpoint in terms of agents, agentic AI, that application in the clinical workflows, in the administrative back office activities, and the patient facing activities and interaction. There's so many use cases here. I mean, it's clearly going to transform healthcare. It's going to transform how medicine is practiced. It's going to transform the administrative elements, how consumers, and I'm going to use the word consumer purposely, engage with the healthcare system and with all of us. There's a massive opportunity here.
So I want to make a comment, and then I have a question for you, Alex. So my comment is targeted towards Ramin. So Ramin, one thing I sense in you, and I used to have this at an extreme level, was deep passion about like what's right and what's not right in the healthcare system, and a desire to fix it. And it's very hard to get traction on the business side when you're extremely passionate on the clinical side, and you have to be able to translate it into the lingo of the other side. You know what I'm saying? So it is something I personally really struggled with. And it's taken me a long time to.
How do you make that shift? I mean, I speak four languages.
I think that's a conversation we can have offline.
Okay.
Please reach out to me. It's definitely something like I've gone through an evolutionary process, and something we all have to learn, because we care. We actually care, right? And that actually can make it sometimes difficult.
Okay, I hear Alex real quick.
Yeah.
I hear Alex, maybe just a couple of examples as you're thinking about this. It may be highlighting how the automation can impact burnout, physician burnout, linking it back to those drivers. It may be how automation can help the clinicians with the coding, right? So they do it compliantly. And they're actually capturing the appropriate disease burden. It may be the AI deployed in a context where the clinical context is crucial, right? You're going to, let's say, come up with an algorithm to understand fall risk, which is going to impact your admits per K, right? There's a whole host of clinical logic that's required to do that. So there might be a way where you can take some of these concepts and then you can link them back to drivers of the business, but do it in a way where you're highlighting the unique clinical experience to help you get the right answer.
If I can go back to initial comment you made, Alex, about knowing the math, right? Can you tell us a little bit about Render? Alex was also CFO and eventually president, acting CEO of an Asian medical group in New York called Render, and how their admits per thousand were so low that, I was the part A affordability guy, and Alex asked me to come in and like sell him some consulting. There was nothing for me to sell because their numbers were so much lower than even the 25th percentile, that any solution that makes sense over here is not going to in any way make sense financially for Render, right? Like, walk me through a little bit of that difference and how the math is so different that, it's just not going to be a priority. People need to find a different channel to come in.
Yeah, so the important element of what Reza is saying here is understanding the context of the business that you're talking to or the business that you're managing. So in Render's case, multi-specialty medical group, 20 plus specialties, the ancillary services, 100 clinics. in 4 of the 5 boroughs in New York, serving roughly 200,000 consumers, largely in risk-bearing entities. These are Asian American individuals. They speak Mandarin, Cantonese, Fujianese, and other dialects, with a clinical workforce that spoke Mandarin, Cantonese, Fujianese, and other dialects. Right, and so that particular ethnicity practiced Eastern medicine. Right, and so there's really this strong family connection, and we actually were studying this at UnitedHealth Group with respect to Singapore, and we were looking at that particular model. But as a result, as Reza said, the Part A spend is very low. The Part B spend is actually higher, and our admits per K, 110. Right, so the likelihood of coming in and having a material impact on particularly if your point solution, right, and our comment about attribution of multiple point solutions is low, right, and so the extent you can understand that, you'll be able to identify whether your solution is relevant to an organization like Render. Because if you went to public company Astrana, as an example, my guess is, and I haven't studied their numbers, but it's probably more of a normal admit per K level, say 300, right? And now your Part A initiatives around admits will really have a big impact.
Alex, when you have solutions and startups pitching you, where you're representing the buyer, there's always a point where they have to kind of explain what the ROI is of their solution. And I'm sure you see both unsophisticated, moderately sophisticated, and very sophisticated ROI calculations. So talk to us a little bit about the variability in the ROI calculations. What are signs of when it's done well? What are some landmines and mistakes that are commonly made?
Mm-hmm. So first, context-wise, 3-to-1, 4-to-1, or higher generally got my interest. Could dip down below that if it was a large quantum. So if it applied to a really large population, right? And so the medical cost benefit, the revenue benefit was really sizable, but maybe it was a 2x return. So in that context, I'm thinking about the focus, thinking about the risks associated with the ability to achieve that savings. I'm thinking about whether it's guaranteed, whether it's not. Those are elements that I'm thinking about. A poorly constructed model would be one where it's coming with general percentages. I've got to believe that it's going to impact, pick a number, 50% of my consumers or my members, and there's another assumption that 20% of the time it's going to have its intended impact on medical costs, or 20% of the time we're going to identify an additional disease, right? So these are generic percentages.
Yeah.
Good and great is you can point to something. We implemented it on ChenMed. Maybe you don't tell me it's ChenMed, but we implemented it on an organization that had was multi-geography, and they had 300,000 Medicare Advantage lives. And when they did that, here are the types of patients that were impacted, and here's what they found, right? So like an actual case where you can get more precise. Absent those kinds of things, I'm typically more curious, I think, than others. And Reza knows this. You bring me an idea, I'm pretty curious about whether it's something that we can do. I would immediately default into some pilot. Let's pick 100, let's pick 1,000. Help me better understand what these percentages are inside of my population before I allocate my precious clinical and other resources to something that I'm not sure about. So these generic percentages, I get very concerned about those. High level of skepticism. You give me precision, you line that back up into case studies, into some other data points, and I feel more comfortable.
let's look at the early stage companies who are looking to get their first pilot or maybe their second pilot, etc. Like when one of our docs here are sitting on that call, once again, I'm trying to figure out what is good and what is terrible, right? Like the when your bullshit meter goes off, what are the things that bother you that someone was on the call and they're like, just because they said this, I don't want to work with this company.
Hmm. Yeah. Well, I'm a small Wisconsin kid, so humility. Humility, number one. If you don't know it, admit it.
Yeah.
So, got a really great idea. We haven't had the chance to deploy that in these other organizations, but it makes sense clinically, and we'd like to try it with you. And we'll make it really easy. Maybe we don't charge you, maybe it's a small sample, whatever it is, but that level of honesty and transparency goes a long ways. So arrogance, not having your numbers, maybe overselling.
Yeah.
Right. I mean, it's pretty easy. Look, it's pretty easy to see somebody who's overselling you, right? Where the benefits just don't make sense. And particularly if somebody can't articulate them in the context of the drivers, right? Or as they're talking about the drivers, they don't understand what a natural level of the admits per KR or what a readmission rate looks like, or what one might expect in terms of the revenue lift associated with particular diagnosis codes. If you don't know that stuff and you don't know it cold, and you don't understand how that flows through my P&L. Yeah, I'm skeptical right out of the gate, and particularly if you start articulating things that are wrong, that are flat out wrong.
You see that all the time. All right, should we open it up to questions to the group, Alex?
Yeah, let's open up. So if you have a question, just click the hand raising button. John, go ahead.
Yeah, kind of going off of Reza's previous question. So as a group of physicians trying to get into the leadership role, what are some of the common misunderstandings that you see physicians saying that kind of makes us kind of put our foot in our mouth, where we're missing the mark when we're talking to CEOs, CFOs, founders? Like, what are some of the dumb things you've heard?
Yeah, well, maybe I can flip it the other direction, and I'll talk to you about some of the attributes that I think, if done well, will create greater credibility for you and put you closer to the being at the table, right? If you do this really well, you'll earn a spot at the table, the decision-making table, relative to these organizations. And these are going to be some themes that are consistent with what we've covered, what we've covered today. Understand the economics, understand the unit economics, and appreciate and understand the value of a member, right? The retention, the consumer, the retentive value. What's the value of quality, the impact of trend, reimbursement, contractual elements inside these organizations. So understand the unit economics. And if you don't know that, work with people offline, work with your CFOs, work with your FP&A leaders, work with others in the organization to understand those. Really embrace data and embrace technology, and be very, very data oriented, right? Put your, as a CMO, the best ones, I think, are really linked into medical economics, right? And who could tell me, at Render as an example, if we served our patients through our internal specialists, because they're higher quality, because they're more cost efficient, we could save $20 PMPM, right? Tell me what the Part B drug spend is on a PMPM basis. But so under embrace data, embrace technology, and then convey it in a relevant way, right? Something that's not relevant would be, telling me about a $2 PMPM item. Again, talking to me about admits per K when the organization admit per K is 100, right? You think Pareto, right? Here are the three largest things. Of those three, this is the thing that's most important. Here's the next most important. So it's embracing data, it's embracing technology, but it's articulating things the way an executive would articulate it, right? And probably in a way how you would articulate it to your patients, right? What's most important? What's next most important? Of the thing that's most important, here are the three things about that are relevant, right? So that kind of context. Make sure you're open, you're curious, you can speak truth to power. Those are all important dynamics. And I guess maybe lastly, it's having an appreciation for a management process and an organization design. And when I think about management process, here our CMO at Render did a great job of this and had an opportunity at the same time, but it was at any particular day, week, month. I had a glide path that they presented to me as it relates to HCC per patient, as an example, understanding the disease burden. There was a glide path relative to quality, right? So at any particular point in time, we knew where we were relative to those measures. That's a management process, right? So being able to put that in place and articulate it, that puts you at the table. That puts you at the table because now you're partnering with the organization and says, you know what, we're slightly off our glide path. You pick a measure here. Let's just say our mammogram screenings are way below, and we need to do something about it. Let's figure out what needs to be done. But you're able to, when you have those management processes, you can frame that up and you can organize the rest of the organization, rally the rest of the organization around things that need to get done. That help, John?
Yeah, no, that's great. Thank you.
Okay, other questions, folks?
Adam Silver, you're on video. We'll call on you. What do you got?
Hi. Yeah. Okay. Thanks. So, all right. I will say that, Alex, as you were describing your response to John's question, I'm picturing myself in a meeting with a executive of a large company that I'm looking to pilot my own project with, knowing that the minutes that you get in front of a high-level executive are precious and limited in time. How would you recommend striking the right balance between what we often hear from Alex Maseni, which is, maybe give yourself the space to under promise and over deliver so that you can impress early on, and speak the executive language while also showing that you want to be learning first. Do you find that when someone is approaching you or wanting to pilot a program with you, that you expect them to know those details of your business in and out, or just be fluent in the language and ask smart questions to convey that they're engaged? What kind of conversation are you looking for, knowing that when we're in that position, we don't have much time to succeed, maybe 20, 25 minutes at the most, I imagine?
I'd probably suggest you do your research first. And so, to the extent you've done that or you've got intuition, so let's say you might not know that Render's admit per K are 100 to 110, but you know the population that we're focused on, right? And so you can probably infer from that population that it's going to embrace Eastern medicine, and Part A is probably likely a smaller component, right? Or if you're talking to a public company, right, or you've got an organization you're talking to and it looks a little like P3, looks a little like Astrana. There's plenty of information out there for you, or it looks a little like Aledade. Right? I would try to do that homework up front so that you have a perspective. And then I think you can answer, you can ask, be a learner too, right? Okay, you're going to ask questions, but you're asking them in the context of putting forth a point of view, right? Alex, I know I've seen, and I would expect that businesses that are focused on the Asian American community probably have lower admits per K, and maybe you have higher prevalence rates of COPD or hepatitis B or whatever it is, right? Is that true? I've suspected that, and our solution really impacts those drivers that are relevant to you. But make sure you get my attention right away. Right. I'll go back to my comments around the PMPM surpluses. I can increase your PMPM surpluses by 10%. Okay. Yeah. Now I'm listening. You got my attention. And you have 25 minutes. So don't take me through page after page of something. Like you gotta be quick, you gotta be sharp, you really have to get to the point. A lot of and this, I should have mentioned this earlier, I think a lot of clinicians go too deep, too long, too much information. Okay, what are the 3 to 5 things you need to know? Get my attention first, and what are the 3 to 5 things I need to know, and then start telling me how we can get there.
Yeah, I think about this as if you're in the ICU, let's say you're the attending of the ICU and there's a third-year medical student presenting the case from yesterday and they're all over the place and it's a disaster. Then the intern takes over and you kind of know what's going on. And then the second-year resident comes in and in 10 seconds tell you the things that you really need to know about the patient, right? Yeah. So your goal is to, as quickly as possible, go from being a third-year med student to even a second-year resident where like you can say, GI bleed, came in overnight, got some blood, blah, blah, blah. Now this is their crate, right? Like something really like cuts through and shows like 5 years of previous education that you've gotten to this point where you can say this in one relevant sentence of why am I, as the attending, like caring about this patient at this moment, right? So with the business stuff, it's the same, right? You start stumbling through God knows what, and having them have the pride out of you. Oh, it's so painful.
Okay,
or you
John,
just lose them. You'd lose me after a minute or two of that. Now I'm no longer paying attention. I'm with you, but I'm not paying attention.
Okay, John, then Allison. Go ahead.
Thank you.
Yeah, so just more questions to have the conversation. So I've been talking to companies who are asking for a clinician partner to be at the marketing table. So the question is, when you're talking about acquisitions, does a physician at the table bring value as opposed to a very well-versed CFO, CEO, founder? If you have an eloquent and financially not dull physician giving the pitch, does that actually make a difference as opposed to if it's some other person who's not a physician?
That's really probably situational dependent. I don't know that you have to have a physician that's delivering all those. So if I thought about all the organizations that I've acquired, there have been various spaces that there haven't been as many physicians who have been the leaders and haven't necessarily needed a physician to be the face of those discussions. But the physicians can help really understand the acquiring entity, really understand who the consumer is and who the patient is that they're serving, what it is that they do that's unique, and then what are the outcomes? Really personalize it. Help bring the solution to life. I think that's one area. And then, we're always thinking about the clinical model, right? And the clinicians and the CMOs have a role in doing that. Just make sure when you're talking to the business people, right? You need to keep your examples need to be easy to understand.
Yeah.
Right. And again, you need to be oriented around the metrics. Here, let me describe our care model. Our care model's got 5 layers, right? The lowest layer is, a large part of the population, right? And we see them, we do this, we see them X. When you get to the top of the pyramid, it's a highly complex population and we're doing X, Y, and Z, right? Those are the types of things that you would be describing. And, again, you need to, I would really, encourage you to start at a high level and then seek some input. Reza, would you like to go, can we take you deeper on this? Do you already understand? Because we can go into greater depth there. And Reza might say, you know what? No, I got it. Makes sense. Take us to the next area.
Got it. So what I understand is being a physician doesn't necessarily in and of itself bring anything to the discussion, only except in a situation where it's a clinical question, then the physician brings value to your acquisition discussions. Okay.
Yeah. I think it's fair. I don't know that I would take away that the clinician's not important and a clinician's perspective, is not important. I just think if I'm evaluating the business and the CEO is a business-oriented CEO, or the CEO is a clinical-oriented CEO, I don't know that I'm immediately going into it and saying the clinical-oriented CEO is better than the business-oriented CEO.
Got it. Thank you.
Allison.
Hey, nice to meet you. Quick question for you. You said something that would catch your attention would be you're going to improve my PMPM 10%. Can you give me an example, a couple examples of what kind of things have crossed your desk in the last year or two that actually did that?
Yeah. So let's see. So one might be one might be solutions that enable the recapture rates of suspects, so better understanding of disease burden at the point of care. So there's some solutions there where you can insert rules into the EMR in a way that it looks native, but you're defining those rules and you're inserting them at the point of care. So that's an example of a solution that increased the PMPM surplus materially. Did it in the context of understanding the disease burden and documenting that. We hadn't gotten there yet, but you could easily use that same tool to ensure you're utilizing a high performing network. Right, here's the referral should go to, in my case at Render, our internal specialists, because we know they've got higher quality, lower cost, and they're interconnected from a data standpoint much better, right? It may be hospital, Maimonides is a better spot for this particular disease state than NYU as an example. I'm making that up, right? Well, you could insert that into the workflow and influence those decisions. You may insert into the workflow as well the elimination of wasted care. And there's some really great examples, and OptumCare has done a lot in this. Things like a stress test, pre-surgical stress test. I don't know exactly what that costs, but the clinical expert at experts at Optum always told me, look, if Alex Mitchell can come he can make his way into the hospital, his stress test is done, he's good. We don't need the stress test on top of that. But so, Allison, to your question, the ability to put rules into the clinical workflow in a way that's native to the EMR and doesn't require click-throughs. As an example, let's see, other
Alex, can I ask,
examples.
is it
Yeah.
more likely that you see $100 PMPM improvement on 10% of the patients, or 10% PMPM improvement on all the patients, right? Like,
Well,
are these solutions that try to do something like spread it like peanut butter across everybody, are they more likely to get visibility and traction, or no? Someone owns 10% of the patients, but in this 10%, they're driving an enormous amount of value.
yeah. I think it's more likely what you just said, that it's a smaller subset of patients where there's enormous value associated with it. I think there are fewer solutions that are going to impact every patient by a small amount, albeit, Allison, the example I gave you is one that would apply effectively to all patients, right? But generally speaking, as you think about these solutions, they're probably targeting the ones that are most effective are targeting smaller populations and having bigger impacts associated with it.
Amazing. I know we're coming up on
Thank
time,
you.
so I want to thank you, Alex Mitchell, so much for taking an hour of your precious time to meet with us. And thank you for everybody for joining. About half of the folks here were probably existing ClinX members. For those who are not, please visit our website. We have I think, awesome, vibrant community, and we're helping docs get into executive roles. So Alex Mitchell, again, thank you so much. Really appreciate you. Everybody have a great week. Thank you.
Thank you, Alex. Thank you, Reza. Good to see everyone.
Thank you. Bye-bye.